Hey, CE Impact subscribers, welcome to the GameChangers Clinical Conversations podcast. I'm your host, Josh Kinsey, and as always, I'm excited about our conversation today. GLP-1 receptor agonists continue to make headlines for their expanding role in chronic disease management, but new research suggests they may also affect ocular health. In this episode, we'll discuss what pharmacists need to know about potential risks to ocular disorders with long-term GLP-1 therapy and how to handle these concerns in everyday practice. And it is great to have Jamie Pitlick with us as our guest for today. Jamie, so nice to see you.
Good to see you.
Yeah, welcome. Go ahead and tell us a little bit about yourself. You've been a guest on the podcast a few times, but it's been a while. So we have a lot of new listeners. So let's go ahead and give you a couple minutes to introduce yourself and tell us a little bit about your practice site.
Absolutely. Like you said, I'm Dr. Jamie Pitlick. I am a professor and chair of pharmacy practice at Drake. I've been at Drake for about 7 years. I do have a practice site, even as chair. I'm practicing at least 1 day a week at Iowa Diabetes. Prior to being the chair of pharmacy practice, I was there much to a greater extent, but practicing kind of in the either primary care or endocrinology practice for my whole career since I started as in the academia world.
Yeah, great. That's great. Yeah, and coming previously from academia, I can't imagine why you don't have time to practice more if you're chair of
Right?
the department. Yeah, I'm just so baffled. Yeah, I know that's a lot of work. So, but also along those same lines, again, further reiterating the fact of you giving time out of your schedule to record this with us. So I really appreciate it. So, as I mentioned earlier, we're going to talk today a little bit about GLP-1 receptor agonists. And as we always like to do, just to kind of set the stage for our listeners and make sure that everybody is on the same page, let's review all of the great things about GLP-1 receptor agonists, Jamie, that we have seen their use just continuing to expand. So just refresh our memories on what all we're seeing them used for currently, the spaces that they're in, and just, it shouldn't be news to anyone because it's been all over the news, but let's just review that if you don't mind for a minute.
Yeah. So GLP-1s have been out for a number of years. I think the first one by EDA came out while I was in pharmacy school.
Mhm.
There are people that are using exenatide, but it is not the one that is used extensively. Now we're using more semaglutide or tirzepatide, so Ozempic or Mounjaro, using the brand names for those. So with those medications, they're primarily used for diabetes, lowering the glucose levels, and they're heavy hitters, lowering over 1%, sometimes 2% on the A1C. So great glycemic control and benefits coming from it.
Mm.
But because of the other effects that it's doing on the body, slowing down weight loss, or slowing down how fast the food moves through the body, making you feel full faster, feel full longer, we're seeing significant weight loss, especially with those last two, the semaglutide and tirzepatide.
Mm-hmm.
And with the tirzepatide, just to be 100% clear, it is a dual agonist. So it's working on two different incretin hormones in the body. It's the GLP-1 and the GIP. So it's kind of hitting two of those mechanisms.
Mm.
So with that weight loss, though, we're getting to see other benefits from them. And you will see news articles, you will see medical journal articles coming out all over about it. I did a talk last year on this, and just the amount of articles I collected on it, it was like chronic kidney disease. There's semaglutide and heart failure, tirzepatide being studied in MASH,
Mm.
which is the new version of
Right.
NASH. Now we're
Mm-hmm.
calling it MASH.
Yep.
Tirzepatide also has the evidence for use in sleep apnea. They're
Mm-hmm.
looking at it in peripheral arterial disease, and also very, very preliminary studies in Alzheimer. So
Mm.
you named some of the big disease states, especially if it's hitting a metabolic pathway, they're looking at studying it.
Yeah, yeah. And some really promising things too. I mean, obviously we've already seen the promise and the success of weight loss and If you think through the process, it makes sense for sleep apnea because typically if someone is losing weight and their glucose gets controlled and, all that kind of stuff, then it makes sense that their sleep patterns are better. So I think, the reason for today's episode, we've had a few other episodes on GLP-1s, and I encourage listeners to go back and listen to those because we really hype up a lot of those new things and the promising potential therapeutic uses of GLP-1s. But today's topic is really kind of to dig into a couple of articles that have recently been published. And Jamie and I were talking about this before. It's kind of the first time that there's been some true negative press around GLP-1s, and I don't think it's really picked up a lot yet. But we wanted to kind of dissect these two articles and really look at and see if GLP-1s have a negative effect on some ocular disorders, because that's what these studies suggest. So, and at least, if there is that direct causal link, then we want to train you all as pharmacists as to what you're supposed to do, what you need to know, and how you need to manage those and monitor those and things like that. So, Jamie, would you let's go ahead and start with Article 1. So Article 1 is we're going to be looking at an article that was published recently in JAMA, and it was published in August, an online version of this. And it's semaglutide or tirzepatide in optic nerve and visual pathway disorders and type 2 diabetes. And the original kind of question that they ask here, and this is what I'll pose to you first, so this is kind of set it up, Jamie, is treatment with either semaglutide or tirzepatide associated with an increased risk of nonarteritic anterior ischemic optic neuropathy and other optic nerve and visual pathway disorders? So let's take a closer look at this article. If you want to walk us through maybe kind of what the study found and why it's gaining a little bit of attention.
Yeah. So what they looked at was examining whether these two medications, so the semaglutide and tirzepatide, if they have an impact versus other anti-diabetic medications on the eye health. And they're specifically looking at the optic nerves and some of those ICD-10 codes that go into the optic nerve diagnoses. So it is a retrospective cohort study which examined data that was available through this platform called TriNetX, and all the data was collected and analyzed to see if semaglutide and tirzepatide combined were different than all the other anti-diabetic medications. Just to define what those anti-diabetic medications were, it included not only metformin, your sulfonylureas, it included Actos, it included also other GLP-1s that are considered weaker GLP-1s. So they looked at liraglutide, exenatide, and Tanzium, which is off the market now, but they looked at all of those kind of bundled together in that other category. So they looked to see if the diagnosis of these optic nerve disorders was more common if you were on semaglutide and tirzepatide versus all these other drug classifications. And they looked at a huge number of patients. It looked like it was over 2 million records that they looked at, and eventually whittled it down. And they had about 80,000 patients on semaglutide or tirzepatide versus about 1 million, over 1 million on all these other medications. And that's the number of patients and everything that they looked at. So it was a huge data set.
Yeah.
The other thing is they looked at diagnosis codes. So they looked at ICD-10 codes to see if they were more common or not. And there's a whole series of diagnosis codes that they looked at. Only one of them was that one very specific to the optic nerve, which is NAION. So nonarteritic anterior ischemic optic neuropathy. And that was a very specific diagnosis code that they then honed into but they looked at all sorts of other ones as well.
Mm-hmm.
Now, for those of you that are like me, that had no idea what that was, I
Mm-hmm.
did have to look this up. It is like a blockage of the artery going to the optic nerve.
Okay.
And it is a disease that's caused and has other risk factors. One of them is diabetes, one of them is hypertension, but there's all sorts of other things that go into that diagnosis and that risk and disease state. So
Okay.
it's many things can cause it, essentially.
Sure.
So they looked for this association between, is this diagnosis or are these different kinds of diagnoses more common for tirzepatide and semaglutide? And what they found was for the NAION, it was more common. So there was a higher risk. So the hazards ratio was worse if you had semaglutide, had exposure to semaglutide or tirzepatide. In some of the other optic nerve disorders, there was a small increase as well. And that was for literally what it said was other optic nerve disorders. And then they listed what those ICD-10 codes were. I did not go in and actually see what those ICD-10 codes were, just kind of categorized as
Sure. Sure.
They did find no difference for a few disorders as well. So just to say that there was no association for optic nerve neuritis, papillar edema, and optic atrophy. So those had no association whatsoever. So I found it interesting that there was the small increase. Now, what I found really interesting in the results was I gave you those big numbers, out of the 80,000 patients that had exposure to tirzepatide or semaglutide, 35 patients in 2 years got this disorder, got the NAION.
Okay.
So very small amount. In a percentage, that was at 0.04%. So very small.
Very small. Yeah.
Risk.
Yeah.
And that was compared to 19 people in the matched cohort that had no exposure to those two drugs. So 35 patients versus 19. But because the population size was so big, that statistically was a difference.
Okay.
So if you look at the absolute difference between those two percentages, it was 0.04 minus 0.02. So like 0.02% difference between the results.
Okay.
So it was statistically happening more often, but the rate at which it's happening in the population is very, very rare. I think it's good for pharmacists and anybody going on the drug to know that, there's
an increased risk.
There's an increased risk, but the absolute risk is very low.
Yeah.
And if you look at the benefits of these drugs in all the other disease states, how much it's lowering A1C, over 2% some cases, how much weight reduction you can get if you used it combined with proper diet and exercise education. You can get 15% weight reduction, sometimes anecdotally more. And then we have cardiovascular disease FDA approval for that and benefit. So you look at the absolute risk reduction it's doing to benefit the patient versus that little harm. I feel like your data still is skewing towards the benefit side of it.
Absolutely. And, just in general, we alluded to it, but pointing out that, losing the weight and that's going to bring down blood pressure and then that's going to, help with any sort of other like sleep apnea, or it's going to allow you to exercise more and continue, so it's literally just this kind of cascade effect that these medications cause. And like you said, when you're truly weighing those benefits versus the risks, does this really stand out as a, ooh, so maybe we don't start GLP-1 because they have a very minute chance of getting this very obscure, version of a optic disorder. So yeah, so that's super helpful. So that was the first study. So again, yes, the link is there, but the significance of that link, and when weighed to other pros and cons, does it still make sense to avoid initiating a GLP-1 or continuing a GLP-1? So then there is a second study that we'll look at, and then we'll kind of summarize and talk through some things and give some pointers for what we can do in practice. But the second study also published in JAMA, and it was published in July of this year, 2025, and it says GLP-1 drugs linked to higher risk of age-related macular degeneration. And kind of the setup to this one is people taking glucagon-like peptide GLP-1 receptor agonist had a higher risk of neovascular age-related macular degeneration in a retrospective study, which built on previous findings linking these medications to vision impairment. So again, it appears that we have another retrospective study, and I'll kind of let you do the same kind of outline for this one, Jamie, and then we can kind of just summarize our thoughts and whether or not this should give true pause or concern for initiating GLP-1s. But yeah, go ahead and let's talk about this study a little bit.
Yeah, and this one I didn't have quite as much detail on it, but it is showing that age-related wet macular degeneration. So with that disorder, you have new blood vessels forming in the back of your eye, and it's deemed wet or dry based on if those blood vessels burst or not. Obviously, wet is considered a slightly more serious than the dry because then you're starting to get more acute vision loss and risk for that to happen. So do the GLP-1s possibly increase that? Again, retrospective cohort study analyzing the risk of that exposure for GLP-1s. So all the limitations of a retrospective study that we've already kind of talked about, where it's causation, it's not causation, it's correlation, have to be taken into mind. And then the other thing with the macular degeneration, again, high blood pressure, diabetes itself are risk factors for it. I did read a slightly different study and brought up a different study that said there might be an increase in immediately after starting the medication, but long-term effects of it are unknown. So, and why I bring that up, I liken that a little bit to some not recent, but some findings that we have about SGLT2s. SGLT2s worsen renal function acutely. Right? After we worsen the renal function, it stabilizes and it becomes renal protective.
Yep.
And there's suggestions, or they're starting to look into that direction. Do you acutely worsen this disorder, and then does it long-term stabilize, or what happens? And they're actually doing some studies, not on macular degeneration, but more in diabetic retinopathy on that with semaglutide in the FOCUS study. So they're looking in terms of that. So again, it's something that I give pause to, but with the study being retrospective and kind of short window of time, it's hard to know what to do with that information yet.
Right, because I think that most recent study was like only 6 months of therapy, right? Like, so it wasn't even long-term use. And how many of our patients are on GLP-1s for a greater length of time than that,
Right.
So yeah.
Right.
Yeah.
So it's what's happening long term that I want to learn more about and figure more about. I like these articles both. I think it is very necessary to be aware of this so that we can educate our patients, educate our providers about the information. As you know, things can go out to patients. And so you never know what they're going to listen to or read, and we have to be prepared to address all of their concerns.
Absolutely.
So I think knowing that, and then just saying, they're short term, again, balancing the risks versus benefits of the whole medication. So the risks to the eyes versus the benefits that we've already talked about. The other thing I wanted to bring into play is I do think it's a known thing, but it's something that we sometimes forget about. There was a signal that happened when semaglutide was first studied and released. Because semaglutide is so potent and it drops your glucose so far and so fast, it actually was triggered to show that it possibly could increase your risk for diabetic retinopathy. Insulin has the same signal that happens, because if we go and take somebody's sugar who's glucotoxic in the A1Cs of over 10% and we quickly drop them, the same thing happens where you increase their risk for diabetic retinopathy. That is a known thing with all insulin products. If you read their package labeling, you'll see it in there. The exact mechanism of why that happens is not 100% known. Is it the change in blood sugars in the eyes? Are we changing the fluid levels, like the osmotic pressure that's happening in the eyes? So there's a lot of speculation about what's happening, but these are potent drugs that can really drop your glucose fast. So in practice, when we see somebody who has risk or has history of diabetic retinopathy, who's coming to us with A1Cs over 10, we do want to get their blood sugars down, but we do it in a very slow, very processed manner. So if somebody's young and healthy, we may drop them faster. But somebody who has that eye history, we're a little bit more careful because we don't want to trigger any sort of problems with their eyes. So we do take it a little slower.
Yeah. And, what I'm hearing there is that this is the information from these studies. While, like you said, it gives us, maybe pause for concern and to think through it a little further and to weigh pros and cons heavily for our older patients, especially if they already have a history of some sort of ocular disorder. But it's also not new to pharmacists, right? So we're used to these things that occur that require that beautiful term called monitoring. And so making sure that we are monitoring our patients and that we're doing follow-up care appropriately. And I think that is it's further proof that, these are two things to be on the lookout for and to be mindful of. But I don't think it changes our decision of whether or not to start someone on a therapy right now. At least, again, maybe certain individuals get a bigger discussion, and maybe perhaps it's a collaborative discussion with other members of the interdisciplinary team. But I think it's important just to note that it's also important just to know that this exists and the possible link is there to monitor the patients and to really be mindful of follow-up care and things. So another thing you mentioned that I'll reiterate is, of course, just like you said, we never know when this information is going to leak out to our patients. And so they're going to come to you and ask questions and say, well, I'm not taking this anymore, even though it's helped me lose a lot of weight and it's got my blood sugar under control. And now I don't have to use my sleep apnea CPAP machine. But I heard that it will cause, an issue with my eye and I'll go blind. So, that could very well be the next wave of things that the patients come through and ask about. So I think, one of the key reasons we wanted to talk about it again was to make you aware as a pharmacist so you're not caught off guard and so that you do have the facts now that you can discuss and educate your patients on. So one thing I wanted to go into, again, you mentioned, the challenge of these studies is, again, the limited the fact that it was retrospective and certain things that, give us greater pause as well. But one of the other things that, I talked about collaborating. Any tips or tricks that you've seen with communicating with other members of the team on something like this when if it's if the issue has been raised and now should we stop the therapy, or if it's talking about whether or not to initiate it, like what are some of the things, what are some of the conversations and tips and tricks you can share with our listeners to kind of help in that discussion?
Yeah. And just in all transparency, I work in a clinic. So I'm working right next to the nurse practitioners, the PAs, the doctors.
Mm-hmm.
And so as the patients are asking me questions, I'm answering them just as I say, like, here's the absolute risk, here's what it can cause, um, but look at what it's done for you.
Mm-hmm.
And then I'm talking with the provider right next to me and say, they've got questions about this. They might ask you additional questions. Here's the information. Here's the study.
Mm-hmm.
And I give them kind of a little bit of a synopsis of the study, a 2-minute summary, and then let them know what I know, to help them have a similar message
Right.
for the patient.
Sure.
One of the things I hear a lot of times that the patients, unfortunately, they're like, I don't know who to believe.
Mm.
The internet's saying this doctor's saying this person's saying this, and then
Mm-hmm.
who do I believe?
Sure.
And so if we can have a similar message across the board and be kind of that trusted clinic,
Mm-hmm.
essentially,
Mm-hmm.
um, and cause less confusion.
Yeah, that's great. And something I always used to tell my students as well is it's important to when you do have an opinion and you do have, it's backed with evidence-based studies or recent articles or whatever, it's important to share that with
Mm.
the person you're collaborating with and talking to, as opposed to just saying, "Oh, I've already done all the research and here's the answer." So,
Yeah.
relay that. It's important, right, to make sure that we're giving the evidence so that they can make an informed decision, but we're also definitely sharing our opinion and making sure that they have the facts.
Yeah.
But in the same sense of also, if we're going to, if we have done the risk assessment and we've determined that someone should no longer continue on a GLP-1 in this case, or any other kind of medication, depending on what we're looking at, it's also important to be sure that you have an alternative plan when you go
Yes.
to that other provider as well.
You
So,
tell them what.
yes, exactly. You can't just say, we can no longer do this because you're the medication expert, so you need to have a plan in place. So that's something else that I'll reiterate to our listeners is, again, sometimes it will take some discussions with other members of the team, and always have your facts and details ready. Share your opinion, but share also where you formed your opinion so that they can also form theirs. Um, so again, I think in summary, Jamie, for today, our take home is that, because my take home at least, and I'll let you agree or add to, my take home is that because these medications are so popular right now and are coming up with so many different uses and being used in a lot of patients, I think these types of studies are going to continue to creep up. We're going to continue to see, hey, here's a pause for concern. Hey, here's a potential link. And so what would you say is like the take-home message for our listener with that? Like, this is not going to be the last time we see a GLP-1 potential negative effect come out in a study. So
Mhm.
what's your take-home point for that?
Yeah, I would say always encourage them to continue to take their medicine until talking with their provider so they can
Mhm.
come up with a plan.
Sure.
Um, in terms of this particular area with the eyes, and if they're using it for diabetes, recommending that they're doing the yearly eye follow-up.
Hmm.
The
It's
dilated
key.
eye exam is key because it will catch the diabetic retinopathy, it'll catch macular degeneration, it'll catch glaucoma, all of these different things that can pop up and happen. I'm also a diabetes educator. Um, And as somebody who has that background and in working with these patients, I would say the eye monitoring is one of the ones that all of our patients are pretty low on because
Hmm.
I can't control it. We can control when the foot exam happens. We can oftentimes control the flu vaccines and some of the other things, but I can't control that eye piece. And so getting that and recommending that is so very important.
Well, and Jamie, I would say too, it I think it's probably one of the things that we as pharmacists often forget about too, because those are, the eye world is not one that we're typically involved in. And so we don't have a lot of collaborative, efforts with those team members because it is, you know, not as common, I guess you would say, as, interacting with the cardiologist and endocrinologist and all the other specialists. So I think that, not only is it something that's probably forgotten by a lot of patients or pushed down the list of priorities for a lot of patients, but I would also think that unfortunately we as pharmacists forget sometimes that that's a member of an interdisciplinary team for a patient with diabetes. So yeah, so I think that's a key take home point here as well. So I think we've done it, but I'll let you summarize one more time. What do you think? I always like to finalize the topic for today, but what do you think is the game changer here? What is the one thing for our listeners to walk away from today's session on?
I think that there are risks and benefits to the GLP-1 class. This is the newest one is going to be the risk to the optic nerves and some of the disorders that we talked about today. The absolute risk of it is very low, looking at the overall number of patients that develop disease, but it is potentially there. The
Hmm.
benefit, though, in how much weight loss, how much A1C, the cardiovascular disease prevention, you always have to weigh that out, that side of it as well.
Yeah, yeah, absolutely. Yep. So again, using your clinical knowledge as a pharmacist to weigh the pros and the cons and make an informed decision, which often requires collaboration with the other members of the team. So, yeah, so I think that's key. Well, Jamie, thank you so much for your time. Again, I appreciate you giving us um, a few minutes of your busy schedule. We really appreciate it. So, thanks for joining us today.
Thank you.
If you're a CE Plan subscriber, be sure to claim your CE credit for this episode of Game Changers by logging in at ceimpact.com. And as always, have a great week and keep learning. I can't wait to dig into another game-changing topic with you all next week.